Hello, everyone, and welcome to SoftFil Academy's webinar. First of all, welcome to Dr. Noury Adel. We are so honored to have you with us tonight and to listen to your knowledge and learn from your technique. So thank you so much for being with us.
It's my great pleasure, Hannah. It's always a pleasure to work with SoftFil, and we are gonna spend some quality time today, right?
Yes. Please, can you start sharing your presentation so we can have the first slides?
Yes, sure.
Great,
Here
thank you. I would like to explain everyone a little bit more about how the webinar is going to go. So the webinar is going to last approximately an hour. Dr. Noury Adel will do his presentation, and then we will ask all of your questions. So don't hesitate all along the webinar to ask your questions in the chat or in the Q&A section. But just know that we will answer the questions at the end. We'll try to answer everything. Also, this webinar is being recorded and it will be available on SoftFil Academy's YouTube page and on SoftFil Academy's website from Monday. So I will introduce to you a bit more about Dr. Noury Adel. If you can go to the next slide, please. I'm sure you're all familiar with him already, but I'll give you all the details that there is to know. So Dr. Noury Adel is an oral and maxillofacial surgeon who has been focusing on non-surgical aesthetics for almost 9 years. He is one of the top aesthetic injectors in Egypt, not to mention that he's a well-recognized speaker and trainer in many training programs, conferences, and webinars. He's an official certified trainer for many products, including Rene fillers, SoftFil cannulas, and eye threads. He has been doing trainings on facial aesthetics for plastic surgeons, dermatologists, and dentists. He earned the master's degree in oral and maxillofacial surgery in 2019, along with other qualifications such as a fellowship of the International Academy of Facial Aesthetics, membership of the American Academy of Aesthetic Medicine, and CMAC. Dr. Noury Adel is also known for his scientific researches published in local and international journals, in addition to being the creator of the 3-point lip technique that he is going to present tonight. This technique is most commonly known as the inverted Mercedes-Benz approach. So I will leave you the floor now, Dr. Noury Adel. Thank you so much again. And yes, please don't hesitate to ask all of your questions and we'll answer everything at the end. Thank you so much.
Thank you so much, Hannah, for this beautiful introduction. It's always a pleasure to work with SoftFil, and it is such an honor for me to be a SoftFil Academy expert. So today I'm gonna speak about my own 3-point lips technique using the SoftFil cannula. As I was discussing with my friend, usually lots of speakers will consume too much time speaking about anatomy and very little hints about the technique. Today we are gonna shift this concept. First, what type of procedures can we do for lips in order to enhance our lips? We can do a surgical augmentation using silicone implants. We can inject neurotoxins at the vermilion border in order to relax the orbicularis oris muscle, to do a lip flip, a little bit of eversion for the lips. We can do fillers for augmentations. Sometimes we use smooth threads where we place it at the vermilion border in order to give this crispy border. Some patients where those patients usually have a dehydrated and a loose lip with a loose tissue, we would inject PRP, we inject skin boosters, Profilo, in order to do a lip rejuvenation. And for cases of darkened lips, we usually would use an NDO-AQ switch laser to do a lip depigmentation. But today I'm gonna be more concerned with the 3rd point, which is the fillers for the non-surgical lip augmentation. Let's speak about anatomy. I guess we are all familiar that the face consists of 5 layers. We have the skin, the superficial fat, the muscle, the deep fat, along with the ligaments, and lastly, the bone. In the lips, it's a little bit different. We do have 5 layers. We have the skin, the subcutaneous tissue, which is always my targeted layer for the filler injection. Then we have the muscle, the submucosa, and the oral mucosa. And I want to tell you something. It is very important for all the audience that is watching us to have a little bit knowledge about the teeth and the dental-alveolar structure, because the lips takes their support from the teeth. So usually if you do have any malalignment of the teeth, it would affect the lips. So what's really important right now to know that the subcutaneous tissue, layer number 2, is always your target layer for injection. We do have an upper and lower lip, obviously. The upper lip is takes a blood supply from the superior labial artery and the subalar artery and the septal arteries. The lower lip takes the blood supply from the inferior labial and the horizontal vertical labiamental arteries. And let me do something. I'm gonna draw it actually on myself, like to make it a little bit simple. So if we all bited or grinded our teeth and we palpated the masseter muscle, and we do have the antegonial notch here, the facial artery is gonna go in a tortuous course where it's gonna give the inferior labial and superior labial. Then after that, it's gonna be an angular artery. It's very important to know the depth and the location of the arteries in order to avoid any serious events. All right, guys, I have to wipe this. Okay. Regarding the superior labial artery, 90% of the cases, the artery is bilateral. You are gonna find it on both sides. And usually it comes superior and lateral to the oral commissure. So when I said the facial artery divides like this, the superior labial divides superior and lateral to the oral commissure. Most of the time, you will find the artery running deep, so you need to inject superficial. But again, anatomy is not all textbooks. So this is like the norm. Sometimes there are anatomical variations. That's why the use of ultrasound is very important in our practice. Regarding the inferior labial artery, its course, most of the time, it would divide at the same level of the oral commissure. Sometimes it may be inferior lateral to it or superior, but usually it is at the same level of the oral commissure. And again, most of the time, the inferior labial artery is deep. However, we do have anatomical variations, as I said. As you can see in this case, this is not a fibroma or any neoplastic lesion. This is an artery that is supposed to be deep, but in this particular patient, the artery is superficial. So as I said, if you do have ultrasound, it's gonna be an added benefit in your practice. And if you don't have it, always use your hands. You would palpate the lips, you would examine the lips. If you see any nodule, try to observe it. If it is pulsating, then this is definitely a caliper persistent artery. It's an artery that is superficial. This is something that is an anatomical variation that you should take care of. Again, as I said, we do have the facial artery. Take about 2 centimeters from the corner of the mouth and do a little bit palpation. Don't press firmly, just a little bit press, and you can feel it's pulsating. It divides into an inferior and superior labial artery, and the distance from the oral commissure is 13.6 millimeter, which approximately 2 centimeters. And I'm gonna get back to this because this is gonna affect the point of entry when you do the cannula injection. So now I do have my patient in my clinic. What should I do? First, you should discuss the treatment goal. What is the patient expecting? Does she want a better looking lips? Does she want a big lips? Does she is gonna like show you on her phone? I wanna have those lips for Angelina Jolie, for example. This is very important to discuss with your patient. And assessment is very important. Put a treatment plan, use the consent to avoid any ethical problems. And the anesthesia, again, this is how I do it. I usually put a numbing cream, then I would inject an anesthetic solution. I would use a plain lidocaine, and I do inject my lidocaine here, and right here at the mantle, and one at the midline. So I don't give a dental infiltration or an intraoral infiltration. I would like to prefer to inject all my anesthesia extraoral. Then I'm gonna start my injection. So as you can see, when we examine the lips, we do have a loose lips and a firm lips. In the first picture, where you can see the lips have like lots of fissures and cracks, I don't think this is a good candidate for lip filler. Usually I would put this patient on a protocol to maintain her hydration. I would start doing PRP or skin boosters. Then after the lips get nourished, I would think about doing fillers. This is very important in terms of lip examination. This is a very good research article for Jacob et al. He did classify 10 lip zones for lip injection. I will tell you right now which lip zones that I choose to neglect during my injection. First, I'm not very fond of injecting the philtrum columns. Okay. I'm not very fond of injecting the philtrum columns. So I hope everyone is seeing. So we do have two rods here. We call it the philtrum columns or the philtrum bridge. I don't like to inject it because I don't see that there's anything beauty in doing two rods here. And by the way, if you have a long philtrum length and you marcated or made those rods prominent with the filler, you are gonna give like an excessive philtrum length. So those cases who have a long philtrum length are not good candidate for this. The second thing, usually the arteries here are multi-layered. They can be deep or superficial. So if you are gonna do it with an intradermal injection. But again, I'm not very fond of marcating or making those two lines, the philtrum columns, prominent. The second no zone for me is the midline of the upper lip. I never ever inject here. I'm worsening my lips. That's fine. So I never ever inject here. I would inject at the midline of the upper lip if the upper anterior teeth are protruded or they are not there. Like if she's doing an implant or a crown or a veneer and is not giving her much of a labial support, I may augment this area. But otherwise, I never inject filler here. The third no zone for me is the vermilion. I never ever inject at the vermilion border. And I know this is gonna be like a topic where like many clinicians say yes, others would say no, but the vermilion zone it's an empty zone. So usually when we did the cadaveric dissection, it is an area that is completely empty. When you place filler at an empty zone, it should move. So it would do a local spread or migration, and it will accumulate at the ergotrid area right here. So I don't like to inject at the vermilion zone. The fourth no zone for me is the wet and dry border. So if we inverted our lips like this, we have a line running here and another line running there inside here. Don't approach this line because 80% of the vessels lies in this plane. So you don't want to do a vascular occlusion. But in certain cases like the M-shaped lip, I may approach the line, but with extreme caution, where I would usually do some lateral subcision and reverse stenting. But again, should be done with an extreme caution. So we do have 4 no zones: the philtrum, the midline of the upper lip, the vermilion, and the wet and dry border, unless in exceptions, as I said. As you can see in this patient, the filler spread or did a local migration, and it accumulated at the skin side of the lip here. So usually I would dissolve those old filler. How I do it? I poke the skin with a pilot needle, then I would enter with a 27 gauge cannula, and I would inject my Hyalase or Hylenex, but we don't have Hyalase here in Egypt. I would inject my Hyalase at the skin side and the lip itself. And I would usually do this in different planes in order to dissolve the filler. And I would dilute my Hyalase, which comes at 1,500 units, at a 2 or 2.5 ml saline. You may add lidocaine because it hurts like hell. But again, I use a 27 gauge cannula. I would do my entry point here. I would inject the Hyalase at the ergotrade area.